In the context of end-stage cardiovascular and renal disease, surgical salvage therapies represent the final tier of clinical intervention. These are procedures meant to physically halt the decay of failing biological tissue once standardized medical protocols are no longer viable. Patients typically reach this stage of clinical desperation only after standard revascularization techniques, like coronary bypass surgeries or percutaneous stents, are no longer anatomically possible. When we introduce highly invasive surgical procedures to patients with no remaining options, we encounter a severe diagnostic conflict, separating a genuine physiological rescue from the documented placebo effect that occurs simply by undergoing major surgery. To continuously evolve, the medical community must navigate this efficacy chasm. The only way to filter out the noise of surgical placebos is to evaluate therapies against hard, objective survival endpoints. We can observe exactly how this filter operates by looking at two extremes: a widely adopted legacy cardiac intervention that ultimately failed objective validation, and the 2025 commencement of human trials for cross-species organ transplantation. By examining how clinical guidelines historically identified and corrected their own errors, we gain the required context to accurately evaluate today's most radical experimental biological treatments. In the late 1990s, Transmyocardial Revascularization, or TMR, emerged as a leading surgical intervention for patients suffering from severe refractory angina. The procedure required opening the chest, placing a probe against the beating heart, and firing a holmium YAG laser directly through the left ventricle wall. The physiological theory was straightforward. By creating these artificial channels, oxygenated blood would flow straight from the ventricle cavity into the dying heart muscle, bypassing the occluded coronary arteries entirely. Initial randomized controlled trials, including widely cited studies by Aberge and Jones, produced highly compelling clinical data. Treated patients frequently reported a massive reduction in chest pain. According to the data, a significant percentage achieved a 2-class improvement on the Canadian Cardiovascular Society Angina Severity Scale. This rapid symptom relief occurred in a patient population that had already failed optimal medical management and had zero surgical options. Driven by this overwhelmingly positive patient-reported data, the FDA granted pre-market approvals for TMR laser systems, leading to rapid clinical adoption. The early data painted a picture of a medical triumph. However, that triumph rested entirely on subjective symptom relief rather than any measured reversal of the underlying disease. The clinical consensus shifted sharply following the publication of 2 pivotal trials, Stone in 2002 and Leon in 2005. By utilizing a percutaneous catheter-based version of TMR, these investigators were able to introduce a critical control variable, a sham procedure. In a sham surgical trial, the control group undergoes the exact same anesthesia, catheterization, and recovery process, but the laser is never fired. This is the gold standard methodology for isolating the placebo effect in an invasive intervention. This chart visualizes the outcome of those trials. Look at the lines for subjective angina relief. Both the patients receiving the actual laser channels and those receiving the fake procedure reported nearly identical, highly significant reductions in chest pain. But when we examine objective clinical metrics, specifically 1-year overall survival, exercise duration, and left ventricular ejection fraction, the data flatlines entirely. The procedure provided zero physiological improvement, exposing a massive delta between how patients felt and how they actually survived. As the sham-controlled evidence accumulated, medical policy reversed. By 2023, the American Heart Association and the American College of Cardiology completely removed the recommendation for TMR from their clinical guidelines. In the UK, the National Institute for Health and Care Excellence issued a strict do not use directive, concluding that the severe safety risks of the surgery outweighed the non-existent objective benefits. The TMR story proved that highly invasive procedures carry a proportionally massive placebo effect. As a result, modern clinical guidelines now uniformly reject subjective symptom relief if it lacks corresponding objective survival data. With ineffective procedures removed from practice, the current standard of care for end-stage heart failure heavily relies on hardware when surgical revascularization fails. Physical stopgaps, such as left ventricular assist devices, are implanted to mechanically pump blood and offload the workload from the failing myocardium. However, these mechanical bridges have strict limits in long-term use. They carry high risks of infection, thrombosis, and device failure, and they do nothing to reverse the physiological decay of the organ itself. Acknowledging these constraints, the American Heart Association has highlighted a distinct 2025 shift, transitioning away from physical offloading and toward direct cellular repair. Current clinical research is aggressively exploring methods to remuscularize failing hearts using engineered stem cells, targeting the actual replacement of dead tissue. This cellular focus runs parallel to a major pharmacological shift. GLP-1 receptor agonists, like semaglutide, drugs originally designed for diabetes, are now demonstrating measurable efficacy in treating heart failure with preserved ejection fraction. At the genetic level, investigators identified novel therapeutic targets, such as dwarf microproteins, which show promise in repairing the molecular machinery of the myocardium. Mechanical pumps and systemic drugs merely buy a patient time. Genuine survival requires rebuilding or replacing the failing tissue at the biological level. That requirement leads to xenotransplantation. This theoretical strategy aims to address the deficit of available human organs by integrating non-human biological tissue into human hosts. In 2025, this field crossed a critical threshold when the FDA formally approved Phase 1 human clinical trials for pig-to-human kidney transplantation. This milestone required rigorous preclinical validation. Researchers utilized brain-dead donor models in 2022 to prove initial viability, successfully stepping up to carefully monitored short-term trials in living patients throughout 2023 and 2024, leading directly to these human trials. To function in a human host, the donor swine require specific genetic modifications. Scientists must edit the animal's genome to strip away antigens that would otherwise trigger immediate hyperacute immune rejection. Prior to trial approval, the FDA and the National Kidney Foundation held externally led patient-focused drug development meetings. These sessions established a strict ethical framework, but more importantly, they secured a mandate requiring pre-planned long-term objective follow-up metrics to evaluate true efficacy. Unlike the early days of TMR, xenotransplantation is entering human testing governed by a pre-built regulatory structure. The framework is specifically designed to reject short-term subjective promises in favor of hard survival data. The sunsetting of Transmyocardial Revascularization and the emergence of Phase 1 xenotransplantation trials act as two essential phases of evidence-based medical evolution. The life cycle of a salvage therapy begins with a physiological hypothesis, producing highly promising subjective data. The critical filtering stage occurs during rigorous sham-controlled trials measured against objective survival metrics. Based on this hard data, the path splits toward guideline adoption or clinical obsolescence. Trusting subjective endpoints allows the invasive placebo effect to bypass this filter, risking severe surgical complications for vulnerable patients without delivering physiological repair. Today, this rigorous evidentiary standard serves as the foundation for the 2025 era of cellular engineering and cross-species organ transplants. As medicine pushes into new frontiers, the ultimate discriminator between temporary hope and a genuine biological cure remains the clinical community's unwavering demand for objective survival endpoints.